Bismillahirrahmanirrahim. The quote of the day is from Avicenna. There are no incurable diseases, only lack of will. There are no worthless herbs, only the lack of knowledge. Today, our topic for presentation is HIV, Human Immunodeficiency Virus. I am Dr. Fauzia Iqbal, resident FCPS Medical Oncology on rotation from Mio Hospital, Lahore, under supervision of Professor Dr. Saira Afzal. So, HIV virus is a retrovirus from the family Retroviridae genus lentivirus. It has viral envelope, matrix, capsid, replication enzymes, and the viral genome. The envelope constitutes glycoprotein 120, which binds to CD4 T cells. The glycoprotein 41 helps in fusion. The matrix constitutes of glycoprotein 17. The capsid has glycoprotein 24, which is the most important diagnostic marker. The replication enzymes include reverse transcriptase, integrases, proteases. The viral genome has two identical strands of RNA. This is a picture of the HIV virus. Types of HIV virus are two. HIV-1 is the most common worldwide, 90 to 95%. More virulent and transmissible groups are M, O, N, and P. HIV-2 is less common, 5 to 10%, mostly in West Africa. Less virulent, slower progression, more asymptomatic, and lower transmission rate. This is the pathogenesis. The steps are, first of all, attachment of virus at CD4 receptors, then there is uncoating and fusion, then the reverse transcriptases get activated, migration to the nucleus, integration of the viral genome into the host genome, transcription and RNA processing, and ultimately protein synthesis. These proteins are cleaved by proteases. Then there is virion assembly, and finally virion budding and maturation of the virus. This is a picture of the pathogenesis. If we look at the epidemiology from the data of WHO and UNAIDS 2024, the total people living with HIV are 40.8 million. Those new cases acquiring HIV are 1.3 million, and people dying from HIV related cancers are 630,000 deaths. In adults, the prevalence is 39.4 million, the incidence is 1.2 million, and deaths are 550,000. Among them, in women, the prevalence is 21 million, the incidence is 530,000, and the deaths are 40,000. In men, the prevalence is 18.5 million, the incidence is 650,000, and deaths are 320,000. In children under 15 years, the prevalence is 1.4 million, the incidence is 120,000, and the deaths are 75,000. So, if we keep looking at the global trends, the incidence has decreased by 40% since 2010, and but still high in key populations. And the mortality is mainly due to AIDS-related illness. Most endemic regions are sub-Saharan Africa, which constitutes around 65% of global cases, and high burden of disease in countries like South Africa. Although Asia Pacific and Latin America are less affected, but still there is significant burden of disease. If we look at the HIV epidemiology in Pakistan, the prevalence in adults is 0.2%. Total people living with HIV are 350 to 480,000. Registered cases are 81,000. New infections are 12,000 to 14,000. Estimated actual new infection per year is 48,000. People on ART are 55 to 58,000. The treatment coverage is 16 to 21%. The viral suppression is 7%. And people who know their HIV status are 20 to 21%. So, if we look at the distribution of the new HIV cases by the year 2024 by gender, men constitute 69%, women 20%, children 6%, and transgender people 4.1%. The geographic distribution in Pakistan is high burden in Punjab and Sindh region. The hotspots are Larkana, Mirpur Khas, and Tonsa. The key drivers are unsafe injections, they are the major cause. Then the reason for delay of diagnosis is low awareness and stigma. Then poor screening due to missed cases and higher transmission rate due to drug use, and also migration plays a role in imported infections. So there was a infamous incident of outbreak in Pakistan, that is Sargodha outbreak, mainly at in the regions of Kot Imrana and Kot Momin, Sargodha, Punjab, Pakistan. It was a type of localized HIV cluster, and because of that, the prevalence rose from 1% to more than 10% in the affected areas in the years 2018 to 2019. Hundreds of cases were detected during the screening campaigns, and the main causes of this outbreak was reuse of syringes and unsafe injections and unqualified practitioners, poor infection control in clinics, and higher injection use for minor illness. Then the modes of transmission is most commonly unprotected sexual contact, that constitutes 70 to 80%. Then blood transfusion, it constitutes 10 to 15%. Sharing needles and needle stick injury, less than 1%. Mother to child transmission is 5 to 15% without therapy. Then the modes of non-transmission, which must be known by public health professionals, these are by hugging, handshake, food sharing, and mosquito bites. It does not transmit the HIV virus. Then the population at high risk is male having sex with male, 20 to 25% higher risk per exposure. Then there is people who inject drugs, 10 to 15%, sex workers 5 to 10%, multiple partners, unprotected sex are the reason. Then transgender people 2%, prisoners 2 to 5%, mother to child 5 to 15%. Now the stages of HIV are primary stage, then chronic stage, and then the advanced or acquired immunodeficiency stage. The primary stage or the acute HIV infection, it lasts 2 to 4 weeks after the exposure, in which there is high viral load, flu-like symptoms, fever, rash, sore throat, and lymphadenopathy. Then the chronic HIV or the clinical latency stage, mostly the people are asymptomatic. It lasts 5 to 10 years. The viral replication is at slow level, and there is gradual decline in CD4 cells. Then acquired immunodeficiency syndrome occurs after that due to severe immunosuppression. There is chronic fever, weight loss, diarrhea, rash, lymphadenopathy, and there are opportunistic infections, especially when CD4 cells they decline below 200. And if we look at the opportunistic infections, there are bacterial infections, tuberculosis, it constitutes 30 to 50% most common opportunistic infection worldwide. Then recurrent bacterial pneumonia, 10 to 20%, mycobacterium avium complex, 20 to 40%. Then fungal infections, candidiasis, oral or esophageal, 70 to 90%, very common. Then pneumocystitis, Jaworski pneumonia, 30 to 60%, cryptococcal infection, 5 to 10%, and histoplasmosis, 5%. Then the viral infections include cytomegalovirus, 5 to 20%, which is cause of most common ocular infection. Then herpes simplex virus, 5 to 10%, varicella zoster, 10 to 20%, Epstein-Barr virus, 5 to 10%, human papilloma virus, 20 to 40%, and JC virus, 2 to 5%. It causes progressive multifocal leukoencephalopathy. Then protozoal infections, among them toxoplasmosis, 10 to 30%, they cause CNS abscesses, cryptosporidosis, 5 to 10%, cause diarrhea, and isosporiasis, 2%, they cause tropical diarrhea. Now, this is a list of opportunistic infections and the CD4 count cells at which they present. So, tuberculosis can occur at any CD4 count, and it causes pulmonary and extrapulmonary infection. Candidiasis occurs at CD4 count less than 500, causes oral lesions and esophagitis. Then PCP occurs at CD4 less than 200, it causes pneumonia. Toxoplasmosis occurs at CD4 level less than 100, causes encephalitis and brain abscesses. Cryptococcal infection occurs at CD4 less than 100 and it causes meningitis. Then cryptosporidosis occurs at CD4 levels less than 100. It causes diarrhea. Cytomegalovirus, it occurs at CD4 levels less than 50. It causes retinitis. Then Mycobacterium avium complex, again at CD4 levels less than 50. It causes disseminated infection. And herpes simplex virus at CD4 levels less than 100. It causes mouth ulcers. Then the malignant tumors that we see in people living with HIV, these can be distributed into AIDS defining and AIDS non-defining. Among AIDS defining, cervical cancer, non-Hodgkin lymphoma, and Kaposi sarcoma. AIDS non-defining, Hodgkin lymphoma, anal, lung, and hepatocellular carcinoma. So, if we look at cervical cancer, mainly caused by HPV high risk strains 16 and 18, and in people living with HIV, this cancer has more aggressive pathway. It occurs even at moderate CD4 levels. So, the screening should be started early at 21 years and should be done frequent every year, and it can be prevented by HPV vaccine. Non-Hodgkin lymphoma, usually high-grade B-cell lymphoma like diffuse large B-cell lymphomas or primary CNS lymphomas or double hit or triple hit lymphomas associated with Epstein-Barr virus infection, and the disease is very aggressive and has poor prognosis and occurs at CD4 levels less than 100. It is the most common cause of cancer-related deaths in people living with HIV and AIDS. Kaposi sarcoma, caused by human herpes virus 8, most common AIDS related cancer, appears as purple red vascular lesions and oral lesions, but in advanced cases it may involve the GIT and lung, and it usually improves with art. So if we look at the diagnosis, the lab tests, they are a screening test, then there are confirmatory tests, then there are non-specific tests, screening, ELISA, and rapid diagnostic test. Confirmatory, Western blot, HIV 1-2 differentiation immunoassays, and PCR, and other supporting tests, CD4 count, baseline, and screening for co-infections. So the rapid antibody test, it detects HIV-1 and HIV-2 antibody. Results are usually in 10 to 30 minutes and common in outreach clinics and resource limited settings. Then ELISA is done by fourth generation. It detects HIV-1 and 2 antibodies and P24 antigen, and it detects early infection within 2 to 4 weeks. Then the confirmatory tests are the immunoassays. They confirm the type of HIV infection, and PCR, it detects HIV RNA, and there is very early detection with this test within 7 to 10 days. Is used in acute infection, blood screening, and infant diagnosis. The Western blot test is an older method. It detects specific HIV proteins but not routinely used nowadays. So the supportive tests are staged according to the stage of the disease, and they detect the opportunistic infection and to use for monitoring our toxicity and response, and for screening of co-mobs include CD4 T cells, CBC, LFT, and RFT. Then co-infection screening for hepatitis B virus, and hepatitis C virus, syphilis, tuberculosis, and chest x-ray and gene expert testing are done. So the opportunistic virus, as the symptoms indicate, they can be done for tuberculosis, cryptococcal toxoplasmosis, cytomegalovirus, and for chronic droidius stool examination is done. Now the management of HIV of AIDS, according to the WHO, the criteria of eligibility is that universal access should be given for all HIV positive patients. For ART, and rapid same day initiation is recommended within 7 days. In pregnancy and breastfeeding, immediate lifelong ART is indicated, and in children, immediate treatment for all children under 5, and in children of 5 years and above, if CD4 count is 500 or less, then ART is indicated. So, if we look at the therapy, when to start the therapy, immediate initiation for all HIV positive patients, regardless of CD4 count and comobs. Early ART reduces morbidity, mortality, and transmission. The preferred first line in adults is of three drugs, and that is tenofovir and lamivudine and dolutegravir. And instead of dolutegravir, if it is not available or if there are contraindications or side effects, efavirenz can be given. So the first line regime in children is abacavir, then 3-TC and dolutegravir, and that is given uh, after the age of 4 weeks, and the dosing is weight based. And in pregnancy, dolutegravir is used unless in the first 6 weeks of conception if there are co-infections like TB or hepatitis. Then in TB, art is usually avoided due to drug interactions, but art is given after the TB ATT drug. So first ATT is started, and then after 2 weeks art is given. So in case of hepatitis B co-infection, those drugs are like tenofovir are included, that are show equal efficacy in both hepatitis B and HIV. So if we see the monitoring, then monitoring of baseline monitoring of CD4 count, viral load, CBC, LFT, and RFTs. And during ART, the viral load is checked at 6 months and then every 12 months, and CD4 is if clinically indicated. So, if the patient is started on ART and the viral load is checked on two consecutive tests done 3 months apart, and there is virological failure, that is, the viral copies are more than 1,000 copies per ml after 6 months. So, second line regime, PI based regimes, they are introduced. Adherence and support is very important. More than 95% adherence is required for viral suppression, and counseling and community support is equally essential. So let's see if there is co-infection of HIV and TB. First, start ATT CD4 cells if less than 50 cells per millimeter cube, and start ART within 2 weeks of starting ATT, right? And if the CD4 cells are 50 or more, then start ART within 8 weeks of ATT. The exclusion is TB meningitis. In that case, ART is delayed, usually 4 to 8 weeks, due to risk of severe immunoreconstitution inflammatory syndrome. So, if there is a co-infection of HIV and Hep B, then first of all, ART is started in any patients with confirmed HIV, regardless of CD4 count. Do not delay the ART because of hepatitis B virus infection, and those ART are chosen that also treat the hepatitis B virus. They include tenofovir and lamivudine, or tenofovir and emtricitabine. These drugs are active against both the viruses. So let us look if there is HIV needle stick injury, what is the post-exposure prophylaxis? The immediate action is that wash with soap and water, do not squeeze, apply antiseptic, report the exposure immediately. Then there is risk assessment of the HIV status of the patient. If he is high risk, he or she is high risk, and then it is assessed whether the injury is deep or hollow bore needle, then that is high risk. And time since exposure is important. So post exposure prophylaxis is started within 2 hours, that is the best time, or it can be started within 72 hours, and after 72 hours usually it's not recommended. So three drugs are given for 28 days, that is tenofovir, disproxil fumarate, emtricitabine, and dolutegravir, and follow-up testing is done at 6 weeks and 3 months and then 6 months. So, the WHO or UNAID targets by 2030 include 95%, 95%, and 95. That is, the first 95% is that all people living with HIV, 95% will know their status by 2030. The second 95 is that all living with HIV, among them 95% will receive antiretroviral therapy, and the third goal is that 95% of all people receiving ART will have viral suppression. So, what are the public health challenges that we face in our society in regarding the management of HIV? These are the stigma and discrimination leads to reduced testing and treatment uptake, and low testing and late diagnosis may cause remain many cases remain undetected. Then poor art adherence lead to failure and resistance, limited healthcare access especially in rural areas. Then there are high risk behaviors like unsafe sex or needle sharing, co-infections like TB, Hep B and C. Then weak surveillance system cause underreporting of cases. Then there is mother to child transmission. It causes inadequate antenatal screening, lack of awareness due to myths and misconceptions, drug resistance due to poor adherence, and legal and policy barriers due to marginalization of the high risk groups. So this was all for the presentation. Now we just look at the MCQs. Number one, which of the following HIV protein is responsible for fusion of the viral envelope with the host CD4 cells? A. Glycoprotein 120, B. Glycoprotein 41, C. Glycoprotein 24, or D. Reverse transcriptase. So the right answer is B. Glycoprotein 41. Number two, which enzyme helps HIV converts its RNA into DNA inside the host cell? A. Integrase, B. Protease, C. Reverse transcriptase, D. RNA polymerase. So the correct answer is C. Reverse transcriptase. Number three, during HIV acute infection, which lab finding is more characteristics? A. High CD4 count and negative PCR. B. Low viral load and positive antibody. C. High viral load and negative antibody. Or D. Low viral load and negative P24. So the answer is C. High viral load and negative antibody. Number four, a patient with CD4 count less than 50 cells is most at risk for A. Pneumocystitis pneumonia, B. Toxoplasmosis, C. Cytomegalovirus, and D. Tuberculosis. So the right answer is C. At CD4 less than 50, he is at increased risk of cytomegalovirus retinitis. Number five, which malignancy is most strongly associated with HHV8 infection in HIV patients? A. Non-Hodgkin lymphoma, B. Kaposi sarcoma, C. Cervical carcinoma, or D. Anal carcinoma. So the answer is B. Kaposi sarcoma. Number six, which test is most appropriate for early detection of HIV infection? A. ELISA antibody test, B. Western blot, C. P24 antigen test, or D. HIV RNA PCR. So for early detection, D. RNA PCR is recommended. C. Which of the following is correct? First line ART regime. A. Single drug therapy. B. Two NRTIs and one integrase strand transfer inhibitors. C. One PI and one NNRTI, or D. Three NRTIs. So the correct answer is B. Number eight, which group has the higher risk of HIV transmission globally? A. Healthcare workers, B. Men who have sex with men, C. Blood donors, or D. Vaccinated individuals. So the answer is B. And number nine, a major barrier to HIV control in countries like Pakistan is A. Excessive art availability, B. High vaccination coverage, C. Stigma and underreporting, or D. Low mutation of virus. So the correct answer is C. And number 10, according to WHO, 95, 95, 95 targets. The second 95 refers to A. 95% diagnosed, B. 95% on ART, C. 95% virally suppressed, or D. 95% vaccinated. So the answer is B. 95% on ART. This is a key of the MCQs that have been discussed. This is the YouTube channel on which this video will be uploaded, and thank you for your viewing.